I have a question real fast
Sure,
about the math, the
sure.
calculations for later on in the term. So I have the 8th edition of the book, and it said that it's supposed to be in chapter 25. I don't see a chapter 25. I don't know if that means that it's supposed to be called a comprehensive
No,
post
what we're
test.
going to do is just the questions in the chapter 24, the review.
Okay.
In fact, let me post that for you all. I've already looked at that because of the change in the edition. I believe it's questions 1 through 40, if I'm not mistaken.
Okay.
And I believe it's all of them, but let me send you an announcement to let you know for Calculate with Confidence. Thank you again. All right, let's go ahead to where we stopped and we'll continue. So we did RSV and now on to tonsillectomy. We know one of the things that children do is that many of them do get tonsillectomies, and we know that they also get a lot of ear tubes put in, adenoids taken out. Very common surgery for your younger children group. So how do we take care of these tonsillectomies, as in teaching the parents, because they're not kept in the hospital anymore. They come in, outpatient procedure, they get their procedure done and are sent home. So one of the things is to avoid irritating and highly seasoned foods because it'll burn, it will hurt. You know, a little side note, I had a brother who, after having the tonsils done in the house by the physician many years ago, he wanted to have radishes with salt on it. And you know what the surgeon said? He says, if he wants it, give it to him. And if it hurts, it's, but if he wants it, and he ate them and he liked them. So, but you shouldn't because it will hurt. No gargling, no vigorous toothbrushing. Let me tell you, those tonsils, they put this big scab at the back of your throat. And can you imagine if you're gargling hard, you hit that scab in the back, it comes off? I'm telling you, it bleeds, and it could bleed to the point of hemorrhaging. And I have seen scabs come off where they're literally spitting and throwing up clots of blood. So, and this kid this little girl went hypovolemic, requiring, having big volumes of fluid put in, go back to surgery and have them recauterized. So very important thing. You should avoid that coughing, clearing the throat, anything in the mouth. Again, protect those clots. Now, ice collar actually helps, putting ice on the throat. A lot of kids don't like the cold, but if you explain why, and remember, vasoconstriction, so that vasoconstriction does help with bleeding. And of course, analgesics. Years ago, they used to give more of like a Hycodan, or it's a synthetic codeine. We don't anymore. Just simple little acetaminophen, Tylenol is basically all they need, and it does work well. Their activity should be decreased so that they're not doing anything that would cause them to breathe hard or, create that clot to burst off. And the one thing about older children, and I wish I would have known because I had my tonsils out at age 21. Chewing gum can prevent throat and ear pain in older children. It's like going underwater and taking your nose and holding it tight and equalizing as you go down. Same sort of concept is that chewing gum, and it can eliminate that pain. So very important thing for your older children. Now, when you first get tonsils taken out, your mouth is going to smell a little bit like old blood, okay? But if it continues, and at age 5 to 10 days post-op, with still a low-grade fever, that little pain and that odor is not normal. That odor should go away. So that means there's an infection going on there. You need to call the doctor at that point. Persistent earaches, fever, cough, again, needs help. And usually within 1 to 2 weeks, they can go back doing what they were doing. Now, pneumonia is a consolidation of one of the lobes of the lung, basically. So there's this thick, mucus that is in the lung, and it's preventing airway exchange. So we can see it's going to be harder to breathe, oxygenate, and it's also a bacteria. So there'll be a fever going on. One of the things that I have seen with your pneumonias and taking care of many of them for quite a few years in the emergency room, these children would come in with a complaint of fever, vomited once, and the fever is 101 to 105, 101 to 102, like 1015, normal number. So between 101 and 102 was never higher, usually not lower. And with that little cough and that vomit, and of course they're not going to want to eat, but those are the symptoms that I would see with pneumonia. Again, with pneumonia, they're going to have to take their antibiotics till it's finished, because usually it's bacterial, and we usually, no matter what, we'll be treating the pneumonia when we see consolidation in the lungs. And you can hear, when you listen to breath sounds, a decreased area. You don't hear that breath sound in that lobe. I used to make it fun when I see the symptoms and say, cough, vomiting, fever is 101.5. Listen, oh, I hear that left lower lobe is decreased. I bet you it's a left lower lobe pneumonia. And I couldn't wait till the x-ray used to pop up on the screen, and then I could look, oh, I was right, left lower lobe. Just make life fun, as being a nurse, seeing many patients coming through. But it can be that mycoplasma, more difficult to take care of. It just takes double antibiotics in a longer period of time. And today we do have a vaccine out for it that is given. Now, pertussis is a disease that, or whooping cough. And let me tell you, you whoop like a cough. I was very young and I had this cough. But I wasn't really all that sick. I just had the cough that went with it. We do have a vaccine for it. Yes, we do. But remember, just because you have a vaccine doesn't mean that you're going to be resistant to it, because many diseases you still can get it. We did have an outbreak down in South Florida several years ago, and the causative reason was they had some children that weren't vaccinated. And because those children weren't vaccinated, they got it and they brought it into school systems and daycares, et cetera. And then we had an outbreak of pertussis. It is airborne, highly, highly, highly contagious. And the young infants are at risk. These children get very, very sick. So our goal is not to have it and have our children vaccinated and get those vaccines. Now, children, what do they do and how do they explore the world? In their mouth, right? One of the things they like to use is coins. Now, they don't pick the little dimes or pennies. It's always a quarter. I can't tell you how many quarters I've seen ingested. And if you look at that picture, that's one of my pictures from one of my kids. And it's right there. So what do you see when you see this child? Well, usually these kids can't swallow because it's obstructing, the esophagus, and they can't get stuff down. So they'll be spitting out or drooling. You might or might not see respiratory distress. If it's down far enough, they'll be able to breathe, but it hurts. And it hurts a lot. And because it hurts and they can't swallow, they usually tell their parents, yeah, I swallowed a penny. Well, it's not a penny, it's usually a quarter. So how do we get this out of them? Well, years ago, we used to take them up to the OR, do a bronchoscopy, take clips, and pull it out in the OR. Well, that's a whole hospital stay, isn't it? And it's also a surgical thing where we put them to sleep. Today, we'll do it right there in the emergency room. We'll get a Foley catheter with a balloon on the end, and we'll insert it down the mouth below where that coin is, blow up the balloon, have the child on the surgeon's lap, bending forward, and they pull it and they cough at the same time, and they usually vomit, and then the quarter is on the floor. And I used to tell the child, he's going to pull that and the coin's going to fall on the floor. Whoever gets it first keeps it. So I'm going for it. The kid jumps on the floor to find it. He forgot that hurt. He forgot what was happening because he wanted the quarter. And that is a great distraction for it. Now, after we get that out, we'll watch them for a while to make sure there's no swelling in the airway, but they usually go right home. It's the difference of going to the OR versus just doing it that way and getting them out. And it depends on how they're treated. These children do really great. I mean, I've seen as simple things as a French fry. Little 3-year-old boy eating French fries at the country club with his grandma, inhaled it, choked on it. They couldn't get it up, Heimlicked everything. And the kid came into the ER and we had to do an immediate intubation to try to get it out. It was still lodged. He was sent right up to the OR. He ended up on ECMO, which is you take the blood off, oxygenate it, and put it back in. It's almost like a heart-lung machine. And that child, 3 days later, died with a French fry. So with younger children, making sure that they're in small enough pieces so they don't. So that's just both ends of the spectrum. A quarter did nothing but a French fry, okay? The other thing that can happen is aspiration pneumonia. You know, years ago, we had Johnson & Johnson baby powder, and we put it everywhere because it smelled so good, right? And we kept the child dry. Well, we found out that talcum in the air can go into their lungs and can cause damage to the lungs. You know, ever clean your bath with bleach or something caustic material? You can feel it sometimes burn your lungs. So this is what we're trying to prevent with children. The other thing that we talk about aspiration is feeding. Now, many children have reflux. It means that their food is in their tummy, but it keeps coming up. And we usually can see these infants, they're arching their back. And you can actually feel that food going up their esophagus because it burns. So how do we prevent aspiration because of reflux? Well, it's feeding techniques. That means burping well in between, making sure we're burping well during the feed, not overfeeding, not too frequently feeding, and having them sitting up after they feed to prevent that aspiration. Now, cystic fibrosis, you've got a great case history on it, case study that's open, but basically cystic fibrosis attacks two things. It attacks the mucus in the lungs and in the small intestines. And in the lungs, it clogs it up and it's thick and it's very difficult to try to expectorate it. So these children need to have vigorous respiratory therapy, aerosols, chest PT. They put those little vests on that vibrate real well. And it's usually at least twice, if not 3 times a day. And it is in the intestines, has to do with absorption of food. You can't get the food down. So these children require an enzyme, pancreatase, which helps with that digestion so that we can get food down. Now, when you see a child with cystic fibrosis, usually these children at birth be one of those child that doesn't stool within the first 24 to 48 hours after birth. I mean, most newborns will stool pretty quickly. Well, these won't. So it's one of those little clues. What's going on? And there's several things it could be, but the first thing you know about is cystic fibrosis. Now, if we were to lick that child on the skin, we would taste salt. Now, I'm not telling you to lick the child's skin, but salt is excreted out their skin. So they're going to be doing a sweat test, which measures the sodium, salt, in their sweat. And that would be, do they have cystic fibrosis? So they're losing salt like crazy through that. So we know it's all respiratory, and then it's all about nutrition. Also, because they are not using all their nutrition, they've got extremely foul smelling, really greasy stools because they are not absorbing fat. All of their fat vitamins, they're not absorbing. So you're going to see a child with poor growth, weight gain's not where it should be, and they're eating right, and you're going to see those stools, and then you're going to, maybe their lungs, you're going to see it. But it's both components. It's not one or the other, it's both. So again, we'll be looking for that sweat test. And what is our treatment? Well, we need to keep those those lungs as open and freely moving as possible. Antibiotics are used in inhalation and orally, even IV if they need it to clear up these infections. Again, we want to be able to expectorate those mucus better, so we'll do some sort of thinner to get it up, to try to get it out easier. And of course, liquids to thin it up, to keep it out. Again, all of that chest PT, all those chest vibrator things, turning them over, clapping their chest are stuff that we're going to be teaching our parents, to be able to do. And these children should be active and moving around. I mean, I think if I was teaching a parent, how can you really help the lungs? I think swimming is great. Getting them underwater, they have to hold their breath, right? And that literally creates CPAP or pops their alveoli open because they're holding their breath. And I think most children love to swim. So it's one of those things. But whatever they can do, walking, running, whatever can help there also. This pancreatic medicine, usually called pancreatase, is given immediately before they eat. And then whether it's food or snack, dinner, lunch, breakfast, or snacks, they take a pancreatase. And this is an enteric coated, usually, these little beads. Now, you can sprinkle it on the food, or they can swallow the whole thing if they're old enough. Sometimes it's powder. Again, you can sprinkle it on the food, but just like you would with some of those inhalations that we take in those little squirt things, you're like Atrovent or Pulmicort or Symbicort or Brio, those things, like you have to rinse your mouth out. Same thing with pancreatase, those powders, because it will affect the teeth, okay? And the one thing I think we forget is to increase doses as they get bigger. Yes, it's only been a year since you adjust the dose, but a lot of kids sometimes can grow up 2 inches and 10 pounds, and that dose has to be increased. So always monitor that dose. Now, with cystic fibrosis, women can get pregnant. Okay, it's not a problem, but there are more chances of it not being a normal pregnancy. Okay, now men cannot get a woman pregnant. Something to do with vas deferens, and the sperm doesn't go to the woman, therefore they can't make their partner pregnant. Now, 1 year after a bilateral lung transplant, a man can get his partner pregnant. So it's one of the things you think it's a sentence where they can never, but yes, they can. But it will require them to get bilateral lung transplant, which is quite a thing to say, well, you want a baby, this is what you have to do. But many men will do that in order to have. Now, acute respiratory distress syndrome is sometimes due to some sort of hypoxic injury. It could be drowning, could be one of them, or it could be a car accident where the chest was injured. And even sometimes after some big surgeries, and the lungs are injured and they're upset. As I said, it could be like sepsis, could be that trauma, drug overdoses. We see that in the adolescents. And as I said, near drowning. Now, acute respiratory distress syndrome is where the body does not exchange oxygen and carbon dioxide the way it should. Oxygen doesn't get to the body the way it should. And many times, the lungs, just are there. There's air there, but it's not performing what it's supposed to do. So a lot of times they'll put them on what we call ECMO. And that actually, all that blood tubing there is actually an infant on ECMO. And what they're doing is they're pulling off blood, putting oxygen on it, and putting it back in the body. It has nothing to do with cardiac output. It just does the oxygen work. A lot of times in newborns, you're going to see it for respiratory things like meconium aspiration. That's a big one that you see, or some sort of hypoxic, anoxic episode at birth, which created a lung injury. So these children are in the ICU, monitored. 2 or 3 nurses will be taking care of that child, 1 on the machine and maybe 2 on the child to keep the kids stable. It's a very sick child. Now, CPR, we know we use this, when a child's not breathing or the heart's not beating. Now, if you can imagine having your child in the hospital and you need to do, somebody has to come in and do CPR on them. We know a lot of times that these children need the parents there. I mean, they might be aware or not, but the parents just really need to understand what's happening because they've given up complete control of their child. So we can do 2 things. We can have them stand there on the side, or we can have them right outside the door with somebody standing next to them, letting them know what's going on. Those continuous updates. I've done it both ways. And parents, whether it's good or bad outcomes, do appreciate that they were with their child. Can you imagine if the child died and the parent wasn't the last one to hold their hand? Can you imagine how that would feel? So just remember those things when we're in these life-saving episodes, okay? Now, asthma, very common condition for children. These children, it's this big, swollen, hyper responsiveness of the airway. And it tends to close up and you can't get air. You can get air in, but you can't push it out. So asthma is expiratory, not inspiratory. So it's expiratory stridor. And usually if you're listening to the lungs, it's the end of the breath out. You hear a squeak, and that's about sometimes all you can hear. So air can go in, but it can't get out because it's all swollen. So how are we going to manage asthma? And how are we going to prevent it from occurring or decrease the occurrences? Well, we need to know what the lungs are doing normally. So when the kid's feeling pretty good, we're going to be doing these pulmonary function tests. We want to see what a normal is. Then we're going to find out what allergies or allergens that are causing them to respond to this. Why did it swell? It's an allergic reaction of some sort to something. To find out why, then we can not go around those things, right? If at all possible. Now, we can do different things for children to make sure they get their medicines. Those little things on the bottom left are called spacers. And we put the little mask around their face, and we put their little meter dose inhalers on the end and squirt it once, twice, whatever the dose is. They inhale a couple times and they got the dose. I mean, we could use these on 1-year-old children very well. And if you think about 20 minutes for an aerosol or 2 puffs and 1 minute of doing it, I mean, many parents would prefer to do that, right? So we can use a couple different things. We're going to be using the rescue, your albuterol, your Prevental, whatever your name is for it. Or we're also going to use what we call long-term control. Now, those have a little bit of steroid in them. If we're talking children, the most common that is used will be what we call Pulmicort. And that's morning and night. Again, that's the one that we rinse our mouth out with, okay? Just like Symbicort, Advair, Brio that you would see in adults. Same thing, you have to rinse your mouth out to protect the teeth and the enamel on them. We're also going to be given something called Singulair. It's like a antihistamine for asthma, and it's Singulair given at night. And it can be given to young kids now. It used to be we didn't. The last thing I heard is ages 2 and up. Or sometimes there's exceptions for a really child who's really has bad asthma. And of course, our goal is not to let them get into the asthma attack because they can go into what we call status asthmaticus, which means we can't control it. And then if they're having an episode of asthma, we're going to be giving them corticosteroids, Solumedrol IM, IV. If it's just a little attack, children might get that prednisolone, which is Orapred, a liquid. And that, of course, steroids decreases inflammation, and it does help with it. Okay, now we're going to go into cardiac again. I want you to stop me when you're not understanding. Anybody who wants to meet with me one-on-one because you're not getting something, you just let me know. Now, most of the time we talk about cardiac issues in children, we talk about congenital. That means they're born with it. Sometimes they can get acquired, usually due to a viral infections, like a cardiomyopathy, right? And that can make the heart big and floppy just because of a virus. Think about lupus, and what does it attack? It attacks organs. So lupus can attack the heart also, and it could be something with the environment, or of course, it's something hereditary in the family. All right, here is the circulation of the heart. You need to go back and look at and trace a drop of blood going through the heart. So it comes through the vena cava, whether inferior or inferior, and it goes into the right atrium. So that's the last little bit of blood flow that comes in. So there's little pressure entering there. It goes between the right atrium and right ventricle through the tricuspid valve. Then out of the right ventricle, there's a pulmonary artery and there's a pulmonic valve. So it goes up into the pulmonic artery into those lungs. Comes out of the lungs and it goes to the left atrium by the pulmonary vein. And you know, there's actually 4 of them. I didn't know that for years until I worked into the cardiac intensive care unit. There's actually 4 of them. So it enters into the left atrium. So there's a lot of high pressure there, right? Goes through the mitral valve into the left ventricle. It goes to the body through the aorta and the aortic valve. It goes up the aortic arch and it goes down to the body and repeat, okay? So know the names of your valves and know the names of where things are. Is it on the right side or on the left side, okay? Now, like I told you, I'm gonna teach you something right now about a kink in the heart. So if we look at that red thing, the aorta that comes out of left ventricle, goes up, has 3 little arteries that go up to the head, and it goes around the arch to the body. Well, what if right after the arch, there's a narrowing or there's a kink? Well, that left ventricle is the engine of the heart, right? It's pumping and pumping, and all the blood can't get through. So what are you going to see? Well, blood can't get through, which means the lower extremities, you're going to have decreased pulses, right? Or no pulses. You're not going to see good dorsalis pedis or posterior tibial pulses because there's no blood going there or minimal, okay? But where's the blood going? Well, go back to those little 3 things that go up to the external, internal carotid, up to the head. Blood is going back up there. So an older kid might have headaches or nosebleeds because the amount of blood that's flowing up that way. Because sometimes this is not diagnosed at birth. Sometimes it's just not. It's one of those things that can slip by. Now, all of it doesn't go up there. So it goes back into the left ventricle. Now let's go backwards more. Goes back to the left atrium, and then it goes back into the lungs, and then the blood fills up there. So what would you see? You see a child who's going into congestive heart failure. And sometimes that's how we diagnose it at age 3 or 4 months. The child is in congestive heart failure, and they're also failure to thrive. They're not gaining weight because oxygen's not going where it should be, and the heart's working extra hard to get it there, but all it's doing is filling up the lungs. Okay, that's your first understanding about a hose. So let's take that little kink in the aorta. It is called a coarctation of the aorta. Coarctation. Very simple name. What are you going to see in these congenital heart defects? Well, number one, they're not going to eat well because they tired well easily because they're not getting the oxygen they need. You don't get oxygen, that's your fuel, you're not going to eat. They're going to rest, they're going to be sleepy a lot. Now the heart's working really hard. So tachycardia, like I said, those lungs are filling up with fluid many of the times. So your lungs are going to breathe faster to Kipnick to try to get oxygen around. And because of all this extra work, poor weight gain, activity intolerance, they're not getting the nutrition they need, developmental delays. And sometimes we know it because of history, but many a time not. Now, what do you see with children with congenital problems? Well, you're going to look at a couple different things to try to figure out what's going on. I think the easiest thing to look at a child and look at their color. Are they pink or are they purplish? I mean, this kid to upper right also has a bilirubin problem because he has that orangey red glow too. But you can see also the cyanosis around the eyes and around the lips. And that child, of course, I'd want an oxygen saturation on too, but you can see just a look. You're going to see the way the chest moves. Are they retracting? Put your hand on their chest. Do you feel there's extra buzzing? Listen to it. Are you hearing murmurs going on in there? And then as they get older with these congenital heart defects, because many kids live with these congenital heart defects that we fix as best as we can, you're going to see that clubbing, just like you'd see in older people with COPD with oxygen deprivation, right? You're going to look at the chest, look at the abdomen. You're going to be checking peripheral pulses. Well, that coarctation, you're not going to feel good ones in the lower extremities, right? So something that we might find out there. The heart rhythm and the rate, is it too fast? Is it too slow? Does it look good? Or is it a normal beat? And then, of course, listening. Do you hear, some sort of murmur going on? So how are we going to do some diagnosis? Well, the number one is always an EKG, simple. We're going to look at heart rhythm. Then we're going to do an echocardiogram. And an echocardiogram looks at blood flow, looks at where is it going. And we can see something happening. Once you see an abnormal echocardiogram, get the parents prepared. They are going to be going for a cardiac catheterization. The cardiac catheterization is that who can really determine what's going on with that heart. And there's two things we do with cardiac cath. Number one is the diagnosis, like I said, and then we actually do some for an intervention. Now, if you have a child who has a rapid heart rate intermittently, we call it some supraventricular tachycardia or SVT, or the heart rate goes up and down real fast, normal, real fast, normal. The heart doesn't know what it's doing. Well, we need that pacemaker to be quiet, relax, and beat one beat continually, right? That would be something that we could, there's something going on in that right atrium. It's not that SA node, the pacemaker, something else somewhere is saying beat faster, beat faster. And then the SA node takes over and says, no, don't do that. Well, we can take care of that other little place that's creating this too fast of a heartbeat by doing a little zap with a little bit of a laser. And that's what they do with an intervention. And they can go and stop it from that little area from beating. He's like, nope, you're not going to work anymore, and zap it. There's also other things we've been doing that are very, progressive. They can do VSD and ASD closures in a simple cardiac cath, which is pretty neat, just saying that can be done. So taking care of a child after they come back from a cardiac cath. Well, the cardiac cath, they go into the right groin and in the children, and they will cannulate the femoral artery and the femoral vein. And they'll put dyes and whatnot in there, and they'll look at the way the heart's beating and the way blood is flowing. And when they're done with the procedure, they'll take out these catheters and they'll hold pressure there and stop the bleeding, because it is a big catheter. It is a big vessel. And if you don't hold it, they'll bleed everywhere quickly. I mean, they can lose, a little infant can lose their blood volume very quickly. So when they come back from a cardiac cath, because now they've been moved off the cardiac cath bed to their bed, then they're jostled and moved down the hallway into your room, maybe into your bed, you might have dislodged that clot. And the first thing I'm going to check is that dressing, making sure they're not bleeding. That's number one. Okay. Then I'm going to check pulses. Remember, they've had this big vessels, these big catheters put in there, that it might have a little decreased pulse, decreased flow, but as long as they're having a flow, good capillary refill, you document it, and that's what we'll be watching. We sort of expect it. Another thing is they can eat, they can drink. It's not a problem as long as they're alert enough. We will check blood glucose levels, because sometimes they come back, they haven't had glucose and they're hypoglycemic. So, or they might have gotten some extra sugar and IV fluids in the cath lab, so it might be high. So we always check that blood glucose level. These children will be in bed for 24 hours. You will be checking that dressing and you'll be monitoring their vital signs. But these children, sometimes the older kids, they'll put weights on there. They have those 5-pound sandbags. They'll put it on there. It's like you putting your finger there, making sure it's not bleeding, but not out of bed. Check those dressings, check those vital signs, check the pulses. Now, congenital heart defect, I never knew there was as many as there were until I started working in the area, and then I found it out. It's the most common cause of death after prematurity, and the most common is a VSD. And when you think VSD, those are your Downs children. You're 18, 21, usually those you'll see it in. One of the things that we have to think about is the way blood flows in congenital heart disease. Well, I've given you a couple of hints by telling you blood goes back to the right atrium. It just gets there. So the pressure in the right atrium is low by itself. The blood going into the left atrium is 4 pulmonary veins. That pressure is high. Now at birth, don't we have this patent foraminal valley, that little thing between the right and the left atrium? Sometimes it will flow over there. So we expect those sort of things. So thinking about the kink, big flow, little flow, where's blood going to go? That is the shunt. Now, this is a list of a lot of the most common of your congenital heart defects. So an atrial or a ventricular septal defect, the left side is a lot of pressure, right side has a little, right? I've mentioned that. It's the 3rd time I mentioned it. So if there's a hole between the left and the right, blood's going to go from the left to the right side, whether atrium or ventricle. Well, when it goes back to the right side, what does that mean? Well, that means the blood's going to go back up the right ventricle into the lungs again, isn't it? So it's going to be a increased pulmonary blood flow. They don't need it, but that's what happens because the blood pushes it over, so it'll be flowing that way. Another one of the things that you're going to have to look at, I don't know if you're going to understand it the first time through, something that you're going to have to read also is called a patent ductus arteriosus, or a PDA. This is fetal circulation. This is how the body keeps the blood flowing from the systemic to the pulmonic circulation when you are intrautero, okay? This is a connection between the lungs, the pulmonary artery, and the aorta. So you're going to see blood flowing from aorta to the lungs and lungs to the aorta. It's just part of what they do. And this is a really neat thing that we have that we use sometimes with some congenital heart defects. And we'll go into that as we keep going. We've already learned about coarctation of the aorta and the kink in the hose, and usually that causes your congestive heart failure, right? Fills the lungs up. There are two terms, stenosis and atresia. A is without. Osis, it means there's still room there. So stenosis is a narrowing. That means some blood flows can still go there. Atresia without, there is no blood flow. So aortic pulmonic stenosis, just a narrowing of that valve. Tricuspid atresia, there is no connection between the right atrium and the right ventricle. So how are we going to get blood from the lungs to go to the body? Don't we have that patent ductus arteriosus? And guess what? We give medicines to keep it open called prostaglandins. A slow, continuous IV infusion of prostaglandins keeps that duct open because it's only there when you're inside mommy. You come out, it closes up pretty soon. So this medicine keeps it open, and until we can do a repair, this keeps the baby alive because it keeps oxygen to the body, okay? Tetralogy of Fallot is your most common of all congenital heart defects. It's cyanotic, which means you get periods of blue baby, right? This is the one you see on NCLEX, HESI, exams, everything. Why they pick this one is what they pick. What is tetralogy? Tetralogy is, ever hear of a tet spell? Blue baby spell? The pulmonary artery is a little bit misshapen. The valve is not completely right. And sometimes every now and then, a piece of tissue covers it. So no blood can go to the lungs. So if no blood is going to the lungs, the baby doesn't get oxygen. And the baby turns blue. This happened to me one night, 4 o'clock in the morning. Little Nolan, I'll never forget him. He went from O2 sats of 100, he went to 10 in 2 minutes. That's how quick it occurs. So what do? What is emergence treatment? Well, you take the knees and you put it up to the chest, boom, as quick as you can. And what does that do? The abdominal contents and the chest contents, it changes pressure. When you push it like that, it changes the pressure in the chest and it pops open that whatever's covering it and allows blood to flow. This will be surgically corrected, sometimes at birth, sometimes later. It all depends on that person, the surgeon, whatever they want to do. What's the best? Another thing we see is what we call transposition of the great arteries. Again, another cyanotic. Well, think about this. You've got your right side of your heart, the right ventricle is supposed to go to the lungs, right? Well, it goes to the body. So your aorta is off the right ventricle. And then your left ventricle should be going to the body. It goes to the lungs. So you have the right side to the body, left side going to the lungs, and they're not meeting. How do we oxygenate that child? Patent ductus arteriosus. Again, keeping that child with oxygen until we can pick it up, turn it around, and put it back on in what we call an arterial switch operation. These children, once they're fixed, but it's getting them oxygenated. And if we put on that patent ductus arteriosus, put on that prostaglandins, they usually buy 7 to 10 days so that we can plan surgery instead of having it emergent, okay? Those are the ones you need to know. And that hypoplastic left heart syndrome, there's no left ventricle, there's no muscle. It's the most severe of all of them, and it requires a minimum of 3-stage surgery. So just to let you know what that is. So again, patent ductus arteriosus. Now we can see how important it is. It connects pulmonary artery to the aorta and allows oxygen there. When we put on that prostaglandins, how do we know all of a sudden it's working? Well, many of these children have in central lines, usually an umbilical artery calf, where it's the blood pressure, and it's a continuous monitoring of the blood pressure. Your normal blood pressure on a newborn, you've got the papers, 60/40. Well, when the prostaglandin starts to work, you'll see 60/18. So now we know, yes, they are oxygenating because now you have what we call a wide pulse pressure. Conversely, if we have a PDA open and we don't need it and need to close it, sometimes premature infants are born like that. How do we know giving the medicine will close it, called indomethacin? Well, you'll see the blood pressure go from 60/18. It'll go back to normal, 60/40. So there's little tricks to look and see, how is it working? Is it working? Is it open, or did we close it? So more on the PDA, prostaglandins keep it open, and indomethacin, which is actually an NSAID. It's almost like an IV ibuprofen, believe it or not. It's an NSAID, but it's given in 3 doses, and you can hear that murmur close because it's like a machine-like, washing machine-like murmur. You'll hear it close, and you'll watch that blood pressure change, and it will go back to normal when it's closed. Now, there's a bunch of things here I've mentioned. You can look at your time, all the different defects there. But it just shows you blood flow, the way they move. Now, congestive heart failure. Congestive heart failure could be due to a congenital defect. I've already talked about that with coarctation, right? Or it could just be that left ventricle of the heart is damaged for whatever reason, and it can't pump the way it should. And if it can't pump blood out, it goes back to the area of least resistance, which is the lungs, and it fills up with fluid and blood, right? We're going to see big whiteout on the x-rays for sure. And what is our goal with congestive heart failure? Well, number one, we want them to breathe as easy as they can. This child will not be laying down. This kid would always be sitting up, pulls the diaphragm down, allows them to breathe as easy as they can, right? So we're going to give some furosemide, just like adults. We're going to get the heart working better. Digoxin is given on adults, right? We give it on infants. We just give it mics per kilo dose. And it's an old drug, works really well. So furosemide, digoxin, and we are going to make sure that that fluid comes out. And we do that by monitoring their weight, daily weights, okay? So once the fluid is out, their heart doesn't have to work as hard, and the body's oxygenated a lot better. So digoxin, we give just like adults. Count the apical for 1 minute, check your electrolytes. You don't want a low potassium. Always check your drug level. And the one thing about infants, they can't tell you they're nauseous, which an adult might in dig toxicity, right? Nausea and vomiting are 2 big signs of dig toxicity. An infant, if you see an infant vomit who's on digoxin, your best bet, don't give it, call the doctor. Get a dig level before you give it. Be safe. Can you imagine? You see a vomit, that's all you see. So you really have to be alert with children to make sure that we are that safe. Always make sure that they are breathing the best they can, that they're getting nutrition. Remember, their heart is working harder, in congestive failure. Many times what they'll do is, if they are on breast milk, they might give, put some calories in it. There's a way to do it. Also, if they're on a formula, they, instead of a 20-calorie formula, you could go to a 24 or 27-calorie formula. So we want to make sure they get that nutrition. And again, let the parents know what you're doing. If the kid went into congestive failure, they could go again. Let the parents know the signs and symptoms so they can catch it quick. Hypoxemia, like for instance, hypoplastic leg heart, your normal saturation at birth could be 65 to 75. Normal. And that's where we want it. Now, what happens when your body doesn't have normal O2 saturations? Well, your body says, I need some more red blood cells there to carry around this oxygen and hemoglobin, right? So it starts producing red blood cells. Now, there's no oxygen to go on there, so it continues to produce red blood cells. So you might have a hemoglobin hematocrit of 7, 17, and 51, 18, and 54, where normal is what? 12 to 14, right? Well, when we are producing all of those red blood cells, because hopefully we have somewhere, for that iron and for the oxygen to be, all the cells are there, but it's not doing anything. We call that polycythemia. So polycythemia, the body's trying really hard, but it still doesn't have that oxygen. And as the kid gets older, your older hypoplast, your older children with any sort of cyanotic heart disease will show that clubbing. So always with these children, so complex. I mean, I learned every day when I worked in the cardiac intensive care unit. Loved it. My favorite of all areas I worked. I learned every day. But I taught every single person who would listen to me, whether nurses, nursing assistants, whether it is the mother, the father, or the grandmother, because the more information given out, that these children do a lot better, because they are very brittle. They can really get sick quickly. So these children will be having lots of doctor's visits, lots of outpatient procedures, a lot of hospitalizations and doctors off, all of that. It's a lot of stuff. So get them ready for it. Have them prepared. Let them know what's going on. Have them prepared. The children, as they get older, they have big programs where they come in and they sit with Child Life and they're taught all about, what's going on with their children, what's going to happen, what things look like, what to expect. And always have them understanding this information. So when they go home, we keep that child safe, because there's a lot of stuff to look for and it needs repetition and repetition. So cardiac cath, again, once you see something going on, you're going to prepare them with an echo. You're going to prepare them for cardiac cath. And usually it's just NPO before they go. And remember, the smaller the kid, the least amount of time that they'll be made NPO. Because, for instance, a newborn, which is many congenital heart defects, maybe 2 hours is all you're going to hold them. And they're going to be fed breast milk up to 2 hours before, or Pedialyte up to 2 hours before on those formula-fed babies. Again, when they come back, check that dressing first. Make sure, keep that leg straight, don't bend it, and have, if you can, a tight dressing there. Check those pulses. Bed rest 24 hours. They can't be up and moving around. You can't have the head of the bed all the way up. It puts pressure. Slowly lift it up so that they drink or they eat. They're not going to choke on the food, of course. And again, check that blood sugar. Bacterial endocarditis is some sort of infection in the heart lining. This is one that from now on, these children are going to have some sort of prophylactic antibiotic before procedures, before dental, before anything that invades the body. They will be. Rheumatic fever. Now, rheumatic fever is when we have a strep throat and we don't completely treat it. This is why I always say, make sure parents take their antibiotics and take the whole complete dose of them. So if it's for 10 days, twice a day, give it all of it. Strep throat that's not treated completely, and they walk around with strep throat, can cause rheumatic heart disease, which means heart valve damage. you will see a child which continues with a sore throat, but they're going to get some joint swelling problems. Again, the heart valve's going to be there. Rash, fever is what you're going to see in it. Sometimes it gets to the point where they have chorea, which is their walking and shuffling gait goes on. Now, once we figure out, okay, they come in, we determine it's rheumatic fever, they had a strep throat 2 months ago, they thought it was just a regular sore throat, they didn't get antibiotics. Once we start that antibiotic, and it will be longer term, it could be 1 month, 2 months, depending on symptoms, everything will go away, even the chorea and the shuffling gait, except for their heart valve. Once the heart valve is damaged, and it's usually the mitral valve, it will not be corrected. So making sure that they finish their antibiotic is important. Hyperlipidemia. You're thinking, children? They have high cholesterol? Yeah, they do. You know, we're learning a lot more about children that we never checked with them before. Like, for instance, we never checked blood pressures on children younger than 5. Today, we're checking them, younger kids. 2, at least, we're checking them because we found hypertension in young children. The same thing as hyperlipidemia. And we could correct it just by diet, right? We know after age 2, we don't have to give whole milk anymore, right? That's one of the things. They need the fat younger, but now they're 3 years old. We can do things to decrease the fat in their diet. Children can have fast heart rates, slow, fast heart rates, or they can have irregular heart rates. Again, finding out why and correcting it. Brady dysrhythmias. Actually seen a pacemaker in a child that was less than 2 that we put it in, had a Brady dysrhythmia. So they can get pacemakers. It's about this big, tiny little thing, but yes, it's in there. Remember, they're going to grow and those leads are going to be short. And that's where you're going to run into all of a sudden the kid all of a sudden blacks out because the pacemaker's not working. Could be something that happens. Tachydysrhythmias, we know we could give them medications. For instance, your beta blockers, your Inderal, right? Propranolol, one things that we do. Or they can go get a cardiac cath intervention, and we can zap that foci, which is causing that tachydysrhythmias. And if it's a conduction disturbance, there's all sorts of medicines we can use to help them.
A question on heart rate.
Sure.
A lot of the kids that I take care of, they will, if they're awake and playing, their heart rate will very rarely be a regular beat. However, when they go to sleep, it'll slow down and become regular. And I just wondered why that is.
Well, just think about you breathing in and out. Your heart rate goes up and down just normally. So children that are up and moving around have different oxygen requirements. When they go to sleep, they decrease those oxygen requirements. And that's why. Make sense? Pulmonary artery hypertension. I've actually seen young kids with it where their pulmonary arteries get so inflamed and not inflamed, but they just get very tight and shut off. And what happens is blood can't get through them. And what happens with it, oxygen and carbon dioxide cannot be exchanged. And when they can't exchange, these children are hypoxic. They actually, one of the drugs, believe it or not, they started to use is Viagra for pulmonary artery hypertension because it causes dilatation of the pulmonary arteries. These children, again, they'll be short of breath, any exercise, any movement. And of course, they're not getting what they need. They'll have that chest pain and with hypoxemia, this syncope with it. So many of these children will need lung transplants. I've seen continuous drips of medication given, waiting for it and all sorts of different things, but it can happen to children. Cardiomyopathy, the heart muscle, just not working. It is big and floppy. It could be due to familiar. It could be that deficient metabolic something going on. It could be that little viral disease that I talked about. collagen vascular disease. And usually with cardiomyopathy, they try as long as they can not to do a transplant. But it gets to the point where even putting them on medications to give a tune-up, a rest, it's not working. And then they're going to need a heart transplant. You know, rejection is the biggest cause of death in heart transplant. Now, I got my little Thomas who had a hypoplastic left heart, and we did everything for that heart, and it wasn't working. And at 9 years old, I believe it was, the day before Valentine's Day, he said to his mom and dad, and by the way, amazing, wonderful family, of course. He said, tomorrow I'm going to get my heart. It's heart day. It's Valentine's Day. And the crazy thing is, 4 o'clock in the morning, they got the call, get him ready, and he got his heart. It is now 12 years later, I believe, and he's doing really well. So, you know, when you see those outcomes, you know, it makes you smile. Now, when you have cardiac surgery, you're going to have chest tubes. You can have 1, 2, 3, 4, doesn't matter. You could have a whole bunch of them. The thing with the chest tubes is these children now are awake. Now, chest tubes, sitting in them, when they cough and deep breathe, causes like annoying, you know, pain that's there. It's like a pulling sort of sharpness. Now, when we take these out, and I've had adults tell me this because I've done adult cardiac surgery, and I work night shifts, so we used to pull out all the tubes first thing in the morning. Number one, it hurts. So take vital signs so you know what numbers you're working with, and then give them something for pain. Now, these children need to be told it's going to hurt a little bit, but it's going to go away pretty quick. Let's count to 20 together. And usually by 20, it's gone. It's pretty quick. It's like intense burning, the adults tell me. And then all of a sudden it's like, okay, it's all better. And again, always get on their level. And if the parents are there, if they don't mind, have them facing the child's face so that they're not watching, because I've had parents go on the floor. So have them watch the child and we can get them out afterwards. We take them out when they stop drainings. Now, hypertension, as I said, they can have it. Remember, untreated hypertension in any age, and we heard this with adults, but it can cause damage to your kidneys, right? Well, the same thing for your children. You have high blood pressure, it's not treated, it will damage your kidneys. So you have to be checking it periodically, and that's why we're doing that now. And they are placing them on medications just like adults, but they're going to be doing it in dosages for children. Now, Kawasaki disease, this is one of those diseases I used to love to diagnose because it's so difficult. These children are children that's had some sort of fever, rash, feeling. Not feeling well. It's gone to the doctor, gone back to the doctor. You know, it's 7 to 10 days in, and then that's when they usually will show up at either the urgent care or ER. And by that time, usually you'll see more pronounced rash, but you see that little flaking of the skin, and you'll see blistering, and you'll see cracking of the skin of the palms of the hands and the soles of the feet. You'll also see the lips start to crack, strawberry tongue. And the most significant of all is these glow in the dark eyeballs, but that's usually later on during this disease. Now, Kawasaki is viral, another viral. It's called a systemic vascularitis of unknown cause, but they usually have a virus going on with it. They're the fever, not feeling well type thing. The one big concern about Kawasaki is vascularitis. That means vessels, inflammation. We're worried about the coronary arteries. The coronary arteries can get a bulging or an aneurysm and can burst. So when we have a child with Kawasaki, they're admitted to the hospital. And we need to take care of this vascularitis, which means there may be micro sort of embolus going on there, right? Inflammation could cause, and with this bulging of maybe the coronary artery, we put them on aspirin, and it helps prevent clots and it decreases inflammation, okay? And then we also put them on intravenous immunoglobulins, IVIG. This is the only time we put children on aspirin. So these are all the things: the eyes, the tongue, the lips. You'll have some swollen glands, the hands, the feet, with all of those sort of peeling, blistering, or flaking of skin. So IVIG, high dose, aspirin high dose, and IVIG. Actually, the director of the coronary care unit, his son at age 3 got admitted with Kawasaki. It was just like, why does the cardiac son come in with this? And again, hard to diagnose. Shock, there's all sorts of shock, whether you're adult, whether you're a child. And again, shock, elevated heart rate, decreased blood pressure, decreased perfusion. You know, these children need it corrected as soon as we can, whether volume, medicine, antibiotics, whatever the reason it's caused. But again, always maintaining your airway. So here we go. Surgical closure of the patent ductus arteriosus would do what? That connection between the aorta and the pulmonary artery. That left ventricle is pumping blood out the aorta. PDA is open right into the lungs, so it prevents that return. Understood? And that's that. Well, you know what I'm going to do? I'm going to do the cahoots in the other class, and I'm going to send you that recording. And now you have the recording to the PowerPoint for you, okay? So then you're going to get both. I will be sending you the cahoots anyway, so that you do have it. Does that make sense? Any questions? Anybody who wants to stay with me and go over their exam after class, please, you may. I would appreciate it. I'd love it. I'll go over those concepts you missed. Or if you need to schedule another time, just let me know. Send me a message, and we're going to go from there. Thank you, everybody, for your patience. Appreciate it, always.
Thank you.
Thank you.
Always welcome.
Thank you.